Good morning, good afternoon, everyone. It's a great pleasure to attend the ISICEM 2020. My name is Romain Sonneville, and I will address the problem of neurological complications of COVID-19. So this is my conflicts of interest slide. To start, we know that severe illness may develop in about 15% of symptomatic COVID-19 patients, and that approximately 5% of patients require ICU admission, mainly because of severe respiratory symptoms, acute respiratory distress syndrome, but also less frequently because of extrapulmonary manifestation and sometimes severe extrapulmonary manifestations. Among extrapulmonary manifestations of COVID-19, special attention has been paid to renal problems and thromboembolic complications, especially in patients admitted to the ICU, but also neurologic complications appear to be quite frequent in this population. So one of the first questions to address is SARS-CoV-2 a neurotropic virus? We know that SARS-CoV-2 virus may induce direct viral mediated cell damage through an interaction between its protein and the ACE2 receptor that is expressed in various tissues of the organism. We know that there is also evidence for indirect cell damage, including via different mechanisms, including dysregulation of the RAS, endothelial cell damage and thromboinflammation, and a dysregulated immune response leading to tissue injury, endothelial inflammation and thrombosis, and cytokine release syndrome. We now know that these ACE2 receptors are present in various areas of the brain, including the frontal motor cortex, posterior cingulate cortex, ventricle, substantia nigra, the olfactory bulb, and the middle temporal gyrus. And we also know that these ACE2 receptors are not only present on neurons, but also on glial cells, microglia, the astrocytes, and oligodendrocytes in various areas of the brain. So what are the potential mechanisms of neuroinvasion? We know that there is evidence of transsynaptic viral spread via a classical transcribial route from the olfactory epithelium to the olfactory bulb, and this involves a retrograde transsynaptic transfer. We also know that there is evidence for blood-brain barrier invasion through via infected endothelial cells that can spread the virus to glial cells directly or indirectly via infected leukocytes, which will act as a Trojan horse through the permeable blood-brain barrier. Neuroinvasion has been documented on imaging. This is just an example showing a coronal and an axial view of a patient presenting a typical anosmia symptoms, where you can see basifrontal involvement of the right gyrus rectus as shown by the yellow arrows on the slide. We have also post-mortem evidence suggesting that despite unspecific post-mortem findings in the brain, cerebral focal necrosis, hemorrhage, edema, or spongiosis in non-survivors of COVID-19, there is clearly evidence of positive SARS-CoV-2 RT-PCR in post-mortem brain tissue. This is a study where this positive PCR was found in almost all patients, 8 out of 10 patients in this post-mortem study conducted by the group of Erasmus in Brussels. What about common neurologic presentations? We know from Chinese studies that nervous symptoms are frequent. They occur in about 1/4 of patients, dizziness and headache being the most frequent symptoms. Other presentations, such as impaired consciousness and acute cerebrovascular disease, seem to be associated with a more severe respiratory or systemic illness in this study. PNS involvement was documented in this study in less than 10% of cases. In patients requiring invasive mechanical ventilation because of RRDS, Patients under sedation, very severe. You can see here that neurological signs were observed in about 2/3 of patients in the form of delirium, agitation, or corticospinal tract sign. Brain MRI was abnormal in most patients studied with a leptomeningeal enhancement, perfusion abnormalities, or ischemic stroke, whereas CSF analysis was non-diagnostic in most cases. Systematic reviews suggest that most common neurological manifestations are non-severe symptoms in the form of smell and taste disorders being present in 59% and 56% of cases, respectively, whereas myalgia and headache being present in 25% and 24% of cases. This is the largest systematic review conducted to date on more than 600 patients. So you can see that in the subset of severe or critically ill patients, impaired consciousness at admission may be observed in 12% of cases. What about EEG studies? We have data from critically ill patients showing abnormal EEG patterns in the form of periodic discharges with high amplitude frontal delta waves with absence of epileptic activity in about 20% of patients, suggesting brain injury related to COVID-19. And this was also studied and confirmed in patients remaining unresponsive after sedation interruption, with this typical pattern associated with a persistent non-reactive background to painful stimulus. Brain MRI studies conducted in acute SARS-CoV-2 patients with neurological manifestations suggest that the most frequent complications are of cerebrovascular origin, ischemic strokes being present in 23% of cases, microbleeds in 11% of cases, and perfusion abnormalities, either of ictal or non-ictal origin, being present in 1 out of 2 patients. Other patterns are less frequent, less than 5% of cases in MRI studies. These include cytotoxic lesions of the corpus callosum, multifocal white matter changes, and posterior reversible encephalopathy syndrome. It is clearly important to have a syndromic approach when facing and when dealing with neurological complications of COVID-19. This syndromic approach was first addressed by the group of Queen Square in London, where they studied 43 patients with SARS-CoV-2 infection, and they categorized patients in 3 major categories. The first category was encephalopathy, patients presenting non-specific features of delirium, no distinct CSF or MRI findings, and the outcome was linked to respiratory illness, and neurological outcome was usually good with supportive care in non-severe patients. The second pattern is the inflammatory CNS syndrome that appeared to be less frequent. Patients presenting with encephalitis, with inflammatory lesion, hemorrhagic patterns. Some patients were shown to be steroid responsive, and the outcome was less good as compared to patients with encephalopathy. The third pattern has been previously discussed in this session is the ischemic stroke. Severe strokes associated with prothrombotic states and pulmonary embolism have been described in the COVID-19 neurologic patients. And other patterns involving PNS and miscellaneous central disorder appear to be less frequent. This classification was investigated in a nationwide surveillance study on 135 patients with COVID-19 and neurological symptoms, and you can clearly see that stroke accounted for 62% of neurological complication. There were mainly stroke of ischemic origin. Encephalopathy was observed in 31% of patients, but confirmed encephalitis was present in less than 10% of cases. So we know now that there are several types of complications with different clinical presentation: encephalopathy, inflammatory complications with encephalitis, myelitis, edema presentation. And this complication occur all early during the disease, within 40 days after onset of systematic or respiratory symptoms. It remains unclear whether these complications result from direct viral infection or from a post-infectious or vascular neuropathogenesis, and clearly further research is needed. What about long-term outcomes and perspectives? We know that neurological complication may be present in the long term, and we have data from the most frequent complication from stroke patients with COVID-19. And we know that these patients have a higher risk for severe disability. They have a higher risk of death when compared to non-COVID-19 acute ischemic stroke patient. This is a study that was published by a Swiss group recently. And we know also that from previous studies conducted in other coronavirus subtype infections, that functional impairment, anxiety, depression, and post-traumatic stress disorder is quite frequent in this systematic review. You can see that anxiety occurred in about 50% of cases, depression symptoms in same proportion of patients, and PTSD was found in about 32% of patients. So to conclude, we know that neurologic complications are quite frequent in COVID-19 patients, that encephalopathy is present in about 10% of cases presenting with symptoms at hospital admission, irrespective of severity. We know that these complications occur early, usually within 40 days following respiratory symptom onset. A syndromic approach is mandatory, consisting of MRI, EEG, and CSF studies for patients presenting with neurological complications. Strokes and neuroinflammatory syndromes contribute to a poor prognosis, whereas isolated encephalopathy with non-diagnostic MRI appears to have a better outcome. And ongoing long-term follow-up studies are needed to address the long-term consequences. And with that, I would like to thank you for your attention.